Assalamu alaikum wa rahmatullahi wa barakatuh. Welcome to the channel of Sound Medical Notes. So, in the previous video, we discussed about history, physical examination, investigations in a patient with hypertension, newly diagnosed hypertension. Today, from now onwards, we'll discuss about the treatment of complete guide to the treatment of hypertension. So, let's begin with the name of Almighty. So, treatment can be divided into lifestyle interventions and second one, pharmacological therapy. So, what are the last lifestyle interventions, or what do you advise to your patient for change in the lifestyle? So, non-pharmacological measures are foundational for all patients, capable of reducing systolic blood pressure by 10 to 15 mmHg, equivalent to one drug in some individuals. So, just by following these non-pharmacological measures, nothing but lifestyle interventions, so one can achieve a reduction of systolic BP uh, without having a drug. So if you take one drug and if it reduces 10 to 15 mmHg of SBP, same thing can be achieved by lifestyle intervention alone. So that's the importance of lifestyle interventions. Okay. So let's see what are the lifestyle interventions. Number one is weight reduction. How it affects? Maintain a body mass index of less than 25 kilogram per meter square. Okay. This is important. Why? Every 1 kg reduction of weight reduces the systolic BP by 1 mm of mercury. So every 1 kg reduction of weight reduces the systolic blood pressure by 1 millimeter of mercury. So if someone reduces 10 kg of weight, so he will reduce his systolic BP by 10 mm of Hg. So why it is? Because there is a strong correlation between weight loss and BP improvement. So there is a very strong correlation with weight loss and BP improvement. So higher the weight, higher will be the BP. So if you reduce 1 kg of weight, 1 mm of SBP will be reduced. Second one is DASH diet. Diet for hypertension individuals. What should be the diet? It should be high in fruits, vegetables, low dairy fat. Okay. It should be rich in potassium, rich in calcium, rich in magnesium. Okay, rich in potassium, calcium, magnesium. Overall, it should be rich in fruits. It should be rich in vegetables. Okay, and rich in potassium, calcium, and magnesium. So, how much expected SB protection? 8 to 14 mm of Hg can be reduced. So, it is comparable to one anti-hypertensive drug. Just only by adjusting the diet. Sodium restriction is a very important thing. Okay, so you should take potassium, calcium, and magnesium in a good amount, but you should restrict sodium. So it should be less than 6 gram salt per day, or in easy way, it should be no added salt diet. No added salt diet. Okay. Spicy foods the patient should avoid. So number one is there should be no added salt diet. Number two is spicy foods avoidance. The patient should avoid spicy foods. Okay. So what is the effect of that then? So it will reduce approximately 2 to 8 mm of Hg. So the most important weight reduction is SB reduction is seen with weight. So it is in decreasing order of weight reduction. Second is a DASH diet. DASH diet rich in fruits, vegetables, low fat dairy, rich in potassium, calcium, magnesium. Second, sodium restriction. So this is the things which we should inform the patients with hypertension. So processed foods are major sources for this sodium. So processed foods should be avoided. Okay, packed foods, they have like the chips and the what do you call this one, easy foods, junk foods, all these have high sodium content, so that should be avoided. Then the third one is physical activity. 30 to 45 minutes of aerobic exercise. What is aerobic exercise? Aerobic exercise is nothing but if you do this exercise, there shouldn't be accumulation of lactate in your body. Okay, so if you do 30 minutes of exercise, aerobic exercise, for 5 to 7 days per week, means every day only 30 to 45 minutes of aerobic exercise, for example walking. Okay, walking fast, so that itself reduces 4 to 9 mm of Hg. Brisk walking is effective and it is accessible. Brisk walking. Okay, Alcohol moderation. So less than 2 units in men, less than 1 unit per day in women, reduces 2 to 4 mmHg. Excess intake raises blood pressure and cardiovascular risk. But one thing I want to share here is, so there is something called as reward center and punishment center in the brain. So if you take something which is which give kicks to your brain, the reward center is activated and it will say you to take it more and more and more. So I think, in my perspective, it is the same case with the alcohol. So if you take some amount of alcohol, your reward center is stimulated, and it in the coming time you will take more amount of alcohol day by day, because your reward center is continuously stimulated. So better to avoid alcohol. So some people will say it depends upon us whether to take or not take. It depends upon our control. But in a generalized way, we can't uh, say this openly. So everybody doesn't have that potential to control to drink. So it is good to not to take alcohol. It increases BP risk and cardiovascular risk. So in summary, to summarize the lifestyle interventions, number one, which is the most important, is weight reduction. Number two, dietary control. Number three, salt reduction. Number four, physical activity. Number five, alcohol intake. Okay, these two are diet and this is exercise and this is weight reduction. Number one is the weight reduction. Number two is dash diet and sodium. Number four is physical activity. Number five is alcohol. So these are the lifestyle intakes. So the most important factor which reduces the BP is weight. Then next is dash diet. Next is sodium intake, decrease in sodium. Next is your physical exercise, aerobic exercise. Next is alcohol, decreasing the alcohol intake or quitting the alcohol itself. Let's come to the pharmacological part. So that was about non-pharmacological, but so lifestyle interventions, you can reduce the BP up to 20 mmHg of systolic, okay, equivalent to one drug. So that's the importance of lifestyle. Pharmacological therapy. So how you will start pharmacological therapy in a patient with newly diagnosed hypertension? So what is our aim in pharmacological therapy? The objective is to reduce the incidence of coronary artery disease, heart, stroke, brain, and heart failure. Randomized trials show that lowering the BP by 20 by 10 mmHg reduces the risk of major cardiovascular events by approximately 50%, half. Just if you reduce the BP by 20 by 10, then the risk of CV events reduces by half. Okay. So general principle. So mark ACE inhibitors or ARB as A. Okay, these are major drugs. Beta blockers as B, and calcium channel blockers as C, diuretics as D. Okay, A, B, C, D. There are other drugs like alpha blockers, okay, and mineralocorticoid antagonists like spironolactone, and centrally acting drugs like clonidine, methyl dopa, and moxonidine. Okay, so that we will discuss. But how you will start? Let us discuss that first. Okay, so general principle, start with a combination therapy. Okay, usually the guidelines say at least 2 drugs are usually required. Single pill combinations recommended to improve adherence. That means you are using 2 or 3 drugs, but you should use a single tablet, and in that single tablet you should have all the components. So single pill combinations are recommended so that patient has improved adherence. Patient doesn't forget to take the drug. If you give two drugs or 3 drugs to take multiple times, so patient may forget, so the compliance will be lost. So to improve the compliance, so single pill combinations are recommended. So step 1, dual low dose see the guidelines. Okay, dual low dose combination you should start. Step 1 is dual low dose combination. So initially it was like start remember this like this. If one important point, grade 1, sorry, I will just if the BP is less than or equal to 150 systolic BP, or if the BP is more than or equal to more than 150, okay, less than 150 or more than or equal to 150 SBP, 3 conditions you can see, or the BP will be more than or equal to 180 SBP or 110 DBP. So in this condition, you will start low dose dual combination therapy. How that can be dual combination? AC inhibitor or ARB with calcium channel blocker or diuretic. That means A plus either C or D. Okay. So this is the initial therapy, but you should start with double drug. Okay. Double drug, for example, telmisartan if you are giving, telmisartan plus cilnidipine if you are giving. Cilnidipine is a calcium channel blocker. Okay. This is 10 mg and this is 40 mg. Okay. And if the SBP is less than 150, you should start with double drug, not single drug. So double drug, what you do? Low dose. You have this tablet. So this will become 20 mg and this will become 5 mg. So in patients with SBP less than 150, start with half tablet of this dual dose combination. And in patient with more than or equal to 150 SBP, start with full dose 40 and 10 mg combination like this. Okay. So dual drugs are preferred now. Start with dual drugs with low dose. Okay. That is the step 1. Dual low dose combination A plus C or D. This is the initial therapy. Step 2 is triple combination at full doses. So A plus C plus D. Escalation is required if BP is not controlled. So how frequently you will ask the patient? Remember one important point. 90% of the drugs will show their efficacy. Sorry, FE. I will write here. Show their efficacy in 15 days. So call the patient in 15 days, and 100% efficacy will be after 1 month. Call the patient in 15 days, and if the target is not achieved, you escalate the dose of the drug. And in 15 days, you are seeing that BP is falling, but still the target is, you are near to the target. Just tell the patient to come after 15 days, and after 1 month, you just see the patient's BP. If it is not up to the target, then you escalate the doses of these drugs. Okay. Then the step 3 is called as resistant hypertension. So already it is explained what is resistant hypertension. So full dose combination of full dose triple combination with including a diuretic. If still the target is not achieved, then it is called as resistant hypertension. The guidelines are add spironolactone. Initially 25 mg per daily, once daily, morning dose, or till 50 mg you can give morning, one dose morning. But if spironolactone is contraindicated, then either you can use a alpha blocker like terazosin or doxazosin. This is doxazosin, which is a alpha prazosin and doxazosin. So some Minipress XL, it is by brand name, it is famous. So doxazosin you can use, or you can use a beta blocker. So if there are contraindications to spironolactone, for example, the patient has hyperkalemia, or the patient is a CKD patient. Okay, CKD patient you can't give spironolactone because there is risk of hyperkalemia. So mainly CKD patients. Okay, CKD patients are mainly CKD patients. So you can use either an alpha blocker or beta blocker for resistant hypertension. Step 3. So dual dose combination, then triple dose combination, then add spironolactone or alpha or beta blocker if there is any contraindication to spironolactone. So this is how you give the drugs. Or else, instead of starting, so the guidelines recommend dual dose combination starting, but you can, if the BP is less than 150, so you can start with a single dose combination of AC inhibitor or ARB also. Okay. So this is the same chart which is explaining you the same things which I have explained now. So how to start? See here, adult under the age of 55 years and any patient with type 2 diabetes, start with AC inhibitor with full dose. For example, tell me certain 40 mg. Tell me. Okay. Start with an AC inhibitor or ARB with full dose. There, that dual dose combination is according to some other guideline. So this is NICE guideline, NICE guideline, which is given in Oxford as well as in Davidson. Okay. So that is the latest, I think, recommendation, dual dose combination. But NICE guideline, according to NICE guideline, if the patient is adult under 55 years and any patient with type 2 diabetes, you should start with AC inhibitor. Or what is the concept behind this? So in young patients, young in the sense less than 50 or 55 years of age, This RAS system is very much active. That's why you should start with ACE inhibitor ARB. And in type 2 diabetes, there are many vascular complications. So to avoid that vascular complications, the CV risk is very much high. So you should start with, tell me, means ACE inhibitor or ARB. Okay, if the adult is over 55 years, so the main problem here will be, if it is older than 55 years, it is arterial stiffness. Vasodilation is the main problem. Okay, or if the person is black person of Africa or Caribbean family origin of any age who do not have type 2 diabetes. So those patients, elderly aged patients, more than 50 years or 55 years, okay, or who are black but don't have type 2 diabetes, then you can start with calcium channel blocker. Calcium channel blocker. Now, if not control, you combine this A plus C. Still not control, then you combine this. Step 3. Okay. Still not control, then step 4 is resistant hypertension, as explained. A plus C plus D. Now, in resistant hypertension, first what you will do, you will rule out secondary hypertension causes. Secondary hypertension causes. You will rule out compliance of the patient, whether the patient is taking the drug properly or not. Okay. Third is, you ask for dietary, whether the patient is increased sodium, he is taking increased sodium. So these questions you should ask to the patient. So whether the patient is taking increased sodium, whether the patient is taking the medications properly or not, or if these are excluded, then ask the patient, you should exclude secondary causes of hypertension in these patients. Nothing is there, you add one more antihypertensive drug. The preferred one, as shown, as discussed in the previous table, is spironolactone. But if any contraindications are there, you can add alpha or beta blocker. Okay, alpha or beta blocker. So that's how you should prescribe the, what do you call, this one properly, these drugs, not randomly. So why we are prescribing? So I said no. Why calcium channel blocker there? Because in elderly patient, the main problem is vascular stiffness, and black patients also. Okay. Black patients and elderly patients have this main problem of arterial stiffness. That's why we are using calcium channel blocker. Then A plus C, then A plus C plus D, then A plus C plus D not responding resistant, you exclude causes. No causes, then you add other drug. Okay. So some important points. Choose a low cost ARB. So tell me, sartan is a low cost. Many physicians nowadays, they are using olmesartan, but I don't usually prescribe this olmesartan because it does not have any metabolic good effects, and it does not increase the insulin, it does not decrease the insulin resistance, as well as the cost is also high, and there is a risk of celiac disease with olmesartan, which recent studies show. So many are physicians are prescribing this olmesartan, but I usually prefer telmisartan because metabolically the profile is good, but it depends upon your patient picture, how he has. So there are other sartans. ACE inhibitors I usually don't prescribe because there is a risk of ACE inhibitor cough. But one important one I would say. So the Oxford says that ACE inhibitors are superior to ARBs in reducing the cardiovascular risk. This is important point, cardiovascular risk. And even if you give a low dose ACE inhibitor, it will reduce the CV risk. But Oxford says ARBs have to be given at high dose to reduce the cardiovascular risk. This is one important one you should remember. Okay. So we'll discuss in detail about every class of drugs in the coming video. Okay. Now, choose a low cost ARB. Okay. One thing, choose a low cost ARB. A calcium channel blocker is preferred, but consider a thiazide like diuretic if a calcium channel blocker is not tolerated or the person has edema, evidence of heart failure, or a high risk of heart failure. So calcium channel blocker A plus C or D. So C you should not give to patients who have edema or evidence of heart failure or high risk of heart failure, because calcium channel blocker, they itself produce edema. That's why you should avoid calcium channel blocker in these patients. So instead you should use a diuretic, so that will reduce the pulmonary edema and breathlessness. Okay. Consider a low dose of spironolactone or higher doses of thiazide like diuretic in cases of resistant hypertension. Okay. At the time of NICE consultation, March 2019, not all forms of spironolactone had a marketing authorization for this indication. Informed consent should be obtained and documented. Nowadays, studies show that eplerenone, which is the brother drug of spironolactone, but it is costly, has less side effect and more efficacy in patients with cardiac failure. So you can prescribe this eplerenone in patients with cardiac failure, cardiac patients. okay, or patient's left ventricular hypertrophy. It has more efficacy than spironolactone. But if the patient, it depends on the patient. If the patient is poor, you can prescribe spironolactone to that patient. Okay. Last point, consider an alpha or beta blocker if further diuretic is not tolerated or is contraindicated or ineffective. Okay. So instead, even if after giving spironolactone the PP is high, or if there is some contraindication, then you can choose for alpha or beta blocker. Alpha, prazosin, doxazosin. Beta blocker, metoprolol or carvedilol, nebivolol, atenolol, bisoprolol are these things. Okay. So these are nice treatment algorithm for the treatment of hypertension. Okay. So the first table which we have discussed, that is the latest table, latest guidelines. Okay. Okay. That says you should start with dual low dose therapy. And I have seen what less than 150, you should start with low dose dual therapy or standard dose single therapy like ACE inhibitor or calcium channel blocker. But if it is more than 150, according to the latest guidelines, you should start with full dose dual drug therapy. Full dose dual drug therapy. Okay. Moving on forwards. So this is a very important from Oxford chart. So a core drug therapy treatment strategy for uncomplicated hypertension. What is uncomplicated hypertension? So BP is less than 180 SBP and 110 DBP, or there are no target organ damage, TOD. So this is uncomplicated hypertension. The BP is less than 180 SBP or less than 110 DBP and there is no target organ damage. This is uncomplicated hypertension. So how do you start drug therapy in these patients? So initial therapy, dual combination. Again, see, Oxford is also saying dual combination. Okay. So here, consider monotherapy in low risk grade 1 hypertension. Systolic BP less than 150. I said no. So less than 150. Consider monotherapy less than 150. Or in very old patients, for example, more than or equal to 180 years. So I will zoom it to know better, to see better. So see here. So standard thing is you should start with A plus C or D. But if the hypertension is less than 150, then you can start with and the patient has BP is less than 150 and the patient has low cardiovascular risk, or meaning less than 10% of cardiovascular risk, then you can start with monotherapy. Okay. One condition. Okay. When you should start with monotherapy. Second thing is if the patient is very old, for example, 80 years age is there. So in these two conditions, I will just revise these two conditions. Number one, less than 10% cardiovascular risk, CV risk. So number one, less than 10% cardiovascular risk with SBP less than 150. Number two is more than or equal to 80 age. So these two conditions you can start for monotherapy. Okay. Now BP is less than 150 but the CV risk is more than 10%. Then you should start with dual therapy. Okay. Okay. Now coming to the step 2. So one pill should be used in dual therapy. Step 2 is again one pill, triple combination. So A plus C plus D. Still not controlled, that it is called as resistant hypertension. Then you should use 2 pills, 2 tablets. So 3 in 1, 1 separate. So triple combination, 1 tablet, spironolactone, second tablet. So whenever you are using diuretic, remember you should give the diuretic during the morning or during the early evening, so that if you give the patient the diuretic during night time, he will wake up from the sleep and repeatedly he will go for toilet. So that's why you should prescribe diuretic in the morning and afternoon, early evening, at 4 o'clock, like that. So step 3 is you should use 2 pills. Okay. Add spironolactone 25 to 50 mg OD, or if there is any contradiction, or still this is not so whenever there is resistant hypertension, I said you should exclude compliance of the patient. You should exclude this one, sodium intake. The patient is not controlling the diet, and you should exclude the secondary causes. Then you should, if there is nothing is found, you should give this therapy. Okay. Add spironolactone or other diuretic or a alpha blocker or a beta blocker. Okay. So beta blockers, one important point. Consider beta blockers at any treatment step when there is a specific indication for their use. What is that specific indication? Cardiac indications are the specific indications for beta blockers, and they should be used at any step, may it be step 1, 2, 3. So if you have a cardiac condition, you should start low dose beta blocker. So commonly bisoprolol or metoprolol or nebivolol are used. So for example, like heart failure, angina, post myocardial infarction, atrial fibrillation patients, or younger women with or planning pregnancy. Okay, so pregnant patients, not all beta blockers should be prescribed. Labetalol is safe, so you can give labetalol, okay, 200 to 400 mg per day. So labetalol is a drug. So younger women who are planning pregnancy, which drug you should give if they have hypertension? Labetalol. Next to labetalol is the calcium channel blocker, which is safe in these patients. So nicardipine is usually used. Nicardipine in slow release form. Okay. That's all the thing. So when to use one drug? If the patient has less than 150 and cardiovascular risk is less than 10%, then, or the patient is aged equal to 80 years of age, then you should start with one drug first. Okay, then this is the second table, panel B. Okay, so one pill you should give. Step 1, initial therapy, again dual combination. Okay, so this is in patient who have combination of drug hypertension along with coronary artery disease. So how you should start? Either AC inhibitor A plus B, or C plus D, or beta blocker C plus D or B, or B plus D. So these are the combinations. So one more time I want to write this. Okay, so what are the combinations preferred in patients with coronary artery disease with hypertension? Number 1, A plus B or C. Okay, A plus B or C. Number 2, C plus D or B. Okay, number 3, B plus D. So these are the combinations which are preferred in patients with these patients. So A plus B, beta blocker, calcium channel blocker. Say A is must. Or if there are some conditions where you can't, okay, give ACE inhibitors, you can see C plus, for example, CKD patients, severe grade CKD stage above 4, stage 4 above. Okay, so those patients you can't give ACE inhibitors or ARBs. So C plus D plus B you can give, or you can give B plus D. Here one important point: consider monotherapy in low risk grade 1 hypertension, systolic BP less than 180. Again here, or in very old patients equal to 8 years. So when monotherapy should be, so first NICE guidelines and the latest guidelines are what do you call, consolidated here. So you are knowing well here when to start monotherapy drug and when to start dual therapy drug. Okay, so less than 150, remember monotherapy drug, or old patient. Okay, that's the thing. Okay, so this is the combination. So AC inhibitor, if there is contraindication like severe CKD, then you can replace A with the C plus D or B. Okay, C plus D or B. Again, if there are contraindication, for example, edema is there, CKD, same CKD patient or heart failure patient with reduced ejection fraction. So you have a lot of edema, so you can plan for B plus D. Okay, so remember A plus B or C plus B or D, or B plus D. So that's it. So what is the reason behind that? You already know. So again, one pill, triple combination of one of the above, A, B, C, or C, D, B, or A, C, B, or A, B, D. So these are the triple combinations. Consider initiating therapy when systolic BP is more than or equal to 110 mg in these very high risk patients with established cardiovascular disease. So this is when there is no cardiovascular risk, you should start with monotherapy. So in patients with established cardiovascular disease and who are having high risk, already this was discussed in starting the antivirus. So you should use the cutoff of 130 SBP. This is the cutoff, and DBP cutoff is 85. Okay, 85. This is the cutoff of DBP. So any patient with comorbidity, the cutoff is 130. Okay, but in patient with cardiovascular disease, you prefer beta blockers or diuretics. So this combination you should follow in patient with cardiovascular disease. Okay, valve combination. Again, resistant number, same thing. Two pills you should take: resistant hypertension, add spironolactone, other diuretic, alpha blocker, beta blocker. Okay, that's the thing. So main thing in a patient who are having a cardiac disease, established cardiac disease, beta blockers, calcium channel blockers, and diuretics are focused. Okay, beta blockers you should prescribe to every patient having a cardiac problem. So beta blockers are must for every patient who are having a cardiovascular patient, because in studies, in trials, they have a very good prognosis. They reduce the hospitalizations due to cardiac failure. Okay, they reduce the mortality and morbidity of these patients who are having this cardiac disease. So that's why the takeaway point from this table is you should include a beta blocker. So all these things, these combinations, all these combinations include a beta blocker. See, A plus B here again B, here again B. So you should include a beta blocker when there is a cardiac problem. That is the takeaway point. And the cutoff is 130. Okay. Then comes the CKD. So in diabetes, already the Rais guidelines have said you should include a ARB or AC inhibitor. So ACE inhibitor or ARB should be must in patient with diabetes. Beta blocker should be must in patient with cardiac disease. Now coming to the CKD. So again, same initial therapy, step 2 therapy, triple combination, and step 3 therapy, same things are there. So here you use A plus C, number 1. Number 2, A plus D, either a loop diuretic, thiazide diuretic or loop diuretic. So what you choose here, you are not, what is the takeaway point from here? You are not using beta blocker here. You are not using beta blocker. So CKD patients, you are not using beta blocker. Either you are using A or C or D. So you are not using beta blocker. So when you should consider beta blockers? Consider beta blockers at any treatment step when there is a specific indication for their use. Heart failure, angina, post myocardial infarction, atrial fibrillation, or younger women with or planning pregnancy. Okay. So in CKD patients, beta blockers are not contraindicated, but they are not the first line drugs as the general guidelines say. So CKD patients, you prefer diuretics because of accumulation of fluid, diuretics are preferred. So diuretics are the main thing. Diuretics are preferred in CKD patients. Okay. Again, triple combination A plus C plus D, and if not tolerated, resistant hypertension. So one important point here to remember is a reduction in EGFR and a rise in serum creatinine is expected in patients with CKD who receive BP lowering therapy, especially in those treated with an AC inhibitor or ARB. But a rise in serum creatinine more than 30% from the baseline. If the creatinine is rising more than 30% from the baseline, should prompt evaluation of the patient for possible renovascular disease. So remember one thing, whenever you prescribe AC inhibitor or ARB, you should call the patient back after 1 or 2 weeks and you should assess the serum creatinine, one thing, and second one is potassium. If the creatinine is raising more than 30% from the baseline, then you should stop the drug. And you should evaluate for any renovascular disease. And if there is renovascular disease, you should not prescribe AC inhibitors or ARBs. And if there is no renovascular disease, then you stop the drug temporarily and you start with low dose. Okay. If the potassium is getting raised more than 5.5 milliequivalents, then you should start the drug temporarily. And then again, you can start it at a low dose. But again, if at a low dose it is crossing the limits, then permanently you should stop the AC inhibitors. That's how you start AC inhibitors and monitor the creatinine potassium levels who are receiving these AC inhibitors. But most of the physicians don't do this. But this is very much important. So creatinine should not raise more than 30% of baseline when using AC inhibitors. 30%, for example, if the patient creatinine is say 1.0 at baseline, and after 7 days or after 2 weeks, you are seeing the creatinine as what is the 30% of this? It is 0.3. More than 1.3 creatinine milligram per deciliter, then that means, and some guidelines say 25%. You can take that also. Some guidelines say 20%, 25%, 30%. So you take average 25%. If the creatinine rising to more than 25% is nothing but 0.25, more than 125 milligram per deciliter, then you should exclude renovascular disease. And if it is not present, then you should start at a low dose, then you should gradually increase the dose. If the patient is tolerating well, then continue the drug. If it is not tolerating, permanently discontinue the drug. That's how you prescribe AC inhibitors or ARBs. Okay. And hyperkalemia and this raised serum creatinine is more common with AC inhibitor than ARBs. This is also important to remember. So they are more effective, but more drug side effects are also there. ARBs are not that much effective when compared to AC inhibitor, but they are not having more side effects also when compared to the AC inhibitors. That is the important point. And one important point, so in order to, for example, in CKD patient, if they receive AC inhibitor or ARB, it will reduce the progression of CKD. and also in a cardiac failure patient, it will reduce the remodeling. So one important point to remember is AC inhibitors, if you start at low dose also, they will have the effect on these things. But ARB should be given at higher doses. For example, tell me started at 80 mg to have those effects. What effects? Cardiac remodeling and reduction of progression of the CKD. I think this is enough for today. We have discussed a lot of things. So how to start drug, when to start drug. So 3 conditions you should ask yourself: whether the patient is elderly, whether the patient has diabetes, whether the patient has CKD, whether the patient has any heart disease. Okay, how much is the BP increased? Okay, all those things, all the situation and context you see, and you prescribe the drugs. So this is the, remember, just leave this, remember this nice guideline, and this is European Society guideline, European Society guideline 2018, European Society guideline. Just remember these 2 charts. Okay, if you remember these 2 charts, then everything is okay. Then from the next class we will discuss each drug, each class of drug, and each drug in depth. Okay, thank you for listening.